Alright, hi guys, welcome to the GEP Crash Course series. So today we'll be going over how to structure a human. Trying to be funny there. So we got myself, Ash, got Anaya here, and also got newly qualified Ganesh, who will be going through the session with you. Just at the bottom, you'll see our email if you've got any questions, and we've got our QR code for our Instagram page as well if you want to follow. And we are recruiting new tutors for next year, so if anyone is interested, do pop us an email and we can arrange something. So this is the QR code for the poll, so I'll give you a minute or so just to get that going on your phones. So give it a couple more seconds. Ganesh, are you using the QR code as well, I'm assuming, right?
Yeah, that's correct. Yeah, I'll use it.
Right. I know you got the login, I'm assuming, considering you actually made the polls, yeah.
Yeah, I'm logged in.
Cool, that's fine. So, I think I should be able to handle my own if you want to run away for a little bit.
Okay, cool.
Yeah.
I mean, I'll stay around anyway, but
cool.
Yeah, sounds good.
Cool. Okay, so it looks like we've got most people who joined, so we can get started. So this is the first bit I'm doing, so named it Let's Run a Marathon. So going through mostly like exercise physiology and a little bit of anatomy as well. So we'll start off with an SBA. So you're now an F1 doctor in A&E. Just promoted you guys. It's been a slow day, so your reg decides to start quizzing you to entertain himself. He asked you which type of muscle fiber has the lowest concentration of mitochondria. So I'll open the polls, and if you guys want to put your answers in. I'll give you about 5 more seconds. Okay, I'm going to close the poll now. So there's a bit of a split here. We've got about a few people saying C's and D's, and just very few who said A. So the correct answer is actually D. So I'll go over why. Next slide. So these are your different types of muscle fibers. So just going back to the options here, I put down 1A, 1B, 2A, 2B, and 3. So the only ones that actually exist is type 1, type 2A, and type 2B. The other ones were just there to throw you guys off. So your type 1 are your slow twitch or slow contraction muscles, fibers. So this is more for like endurance based, like exercises, for example, like long distance running, like marathon running, for example. Your type 2 is your fast twitch ones, and there's 2 types, your A and B. So A is kind of in the middle. So it has some resistance to fatigue, but it's not as long lasting as type 1. So it's still got so type 1, because it's for like long distance, high endurance, you'll have a very high concentration of mitochondria because you need that energy source. Whereas type 2A, you've got a bit less than that. And then type 2B is your fast twitch, which is easily fatigued, and it's mostly based on anaerobic respiration. So it has a very low concentration of mitochondria, and kind of exercises that this is linked to is usually like things like sprinting, for example. And then there's just a little bit more information here just for your own learning if you want to go through the table. But these are the key points that you need to remember. So next SBA here. So it seems to be unbelievably slow day in A&Es. So the same Reg decides to ask you another question. Which of these is not a feature of skeletal muscles? So I will open the poll. Give you a few seconds to answer. Give it about 10 more seconds. Okay, I'm going to stop the poll now. So most people have put down C, which is the correct answer, so well done. So just to go through the different muscle types, and just one little point before I go over that, just remember to kind of go over the different organization of muscles in the antagonistic pairs and how they work. And I'll kind of briefly touch on this a bit later on as well, but it's just a key point to just know how antagonistic pairs of muscles work. So just going over skeletal muscles. So these are long and cylindrical structures, and they form these long muscle fibers, and they're multinucleated and striated. So the reason why it looks all like stripy is because that's the way the sarcomeres itself are organized. And I'll come on to it a bit and you'll understand why it's got that stripy feature. But it's all like kind of linearly arranged. And it's very similar to cardiac muscle. But in cardiac muscles, you also have these intercalated discs. And this is what allows that synchronization during contraction and allows the heart to pump continuously and also in synchrony. And then if you kind of think back to things like your MIs and all that, when there's a little bit of damage in one area, this is why the pumping function of the heart kind of goes awry, because you've lost that synchronous like continuity with all the intercalated disc and the muscle itself. And then you've got your smooth muscles, which is a lot simpler. It's for much smaller movement. For example, you find them in like your gut lining and your respiratory tract, and it's just for like smaller contractions. Whereas your cardiac muscles and your skeletal muscles are much larger muscle group, like part of larger muscles, which need larger movements. Cool. So next SBA, the continuing quizzing you guys. So which element of the muscle cell is also known as a dark striations? So I'll open the poll. I'm just going to quickly post the QR code as well in the chat for the polls. Just one step ahead of you. Yay. I'll just give it about 10 more seconds. Okay, I'm going to close the polls now. So this, the answer here is very split amongst everyone. So the correct answer is actually A. So the A band. So I'll go over it in the next slide here. So your A band is your dark band where there's more filaments concentrated in that region. So that's this bit here. So you can see the actin and you can see these myosin filaments here. And because they're overlapping, it's going to look a lot darker. Whereas this region here, it's just the actin filaments. So this is going to be your lighter region, which is where you get the dark and light. And the other thing to note here is your myosin filaments are much larger and thicker, so it's going to appear a lot darker as well. So this lighter region is your M. Sorry. So the M line is like the middle of the myosin filaments. And then your Z line is between that light region where the different sarcomeres are meeting. Your H zone is the other bit that you need to know, is where there is no overlap, and it's just the part of the myosin which it's highlighting there. And the H zone is what gets smaller during contraction, and then it gets larger during relaxation of the muscles. And your I band, sorry, is the lighter region where there's less filaments. And I've put this diagram in here. I'm not going to go over it right now, but you do need to go over the different levels of organization from the muscles itself, as in the large like muscle organ, all the way down to like the myofilaments and how the sarcomere is actually arranged. So next, SBA. So which iron is the most important in the microscopic process of muscle contraction? I'll open up the polls. Give you about 10 more seconds. Okay, close the poll now. So the correct answer is D. So it's calcium ions, which are key for the contraction of the sarcomeres itself, as it kind of aids the formation of this actin myosin cross bridge. And I have a diagram coming up in a little bit, but just before that, I'm just going to go through the neuromuscular junction itself. So within the neuromuscular junction, you've got this, you've got your motor neuron coming here, it's synapsing here, and then you've got your acetylcholine, which is a neurotransmitter at the neuromuscular junction, which is released, goes and binds on the receptors on the muscle itself. And this basically then goes through to the sarcolemma and it generates the action potential through down into the T tubules. And this then releases your calcium. The calcium then goes and binds onto the troponin, and that kind of causes a change in the configuration, causing the myosin heads to latch on to the actin and then kind of drags it towards the center of the sarcomere. And this is what kind of leads to your contraction. And then on the next slide, it kind of just goes into a bit more detail. And I put so when you get the slides, you'll see that I put a link to like a YouTube video, which I found quite useful. So do have a look at that as well. but just kind of going into a little bit more detail. There's an active site on the actin filaments itself, which gets exposed when the calcium binds to the troponin, and this is where the myosin head binds. So the myosin goes and binds to this, forming the cross bridge, like I said, and this causes it to kind of rotate, and this is what kind of drags it forward. And the key bit to remember here is it drags the actin towards the M line. So this process releases your ADP and the phosphate, which is bound to it. And the way this is undone is by a new ATP coming along, and it binds to the cross bridge itself and causes it to kind of reset essentially. And then the ATP hydrolyzes, but it stays attached. And this is what allows the myosin to kind of go back to its original position. And this myosin, it's just kind of, it usually kind of lies flat against, the myosin heads lie flat against the myosin filament itself. Okay, so next SPA here. So all of a sudden, the paramedics rush in with a 40-year-old patient, Homer. He collapsed whilst trying to race against his neighbour Ned in a marathon. Your Reg wants to know which of this is not a cause for his collapse. So I'll open up the polls. Give it about 5 more seconds. I think everyone's mostly answered here. Okay, closing the polls. So everyone's put down A, which is the correct answer, so well done. So obviously being well rested is never a bad thing. So having 10 hours of sleep before a big event, 10 hours might be a bit too much, but having a good amount of rest before a big event is always recommended. The rest of it would have actually contributed to his collapse. So without being sufficiently hydrated, for example, he'd end up being more prone to being dehydrated during the event. Just generally poor training, not eating well, and also being hungover on the day because he's been drinking that night is not going to help either, and it'll just make him feel really unwell and also very unprepared. Just going on to option D. So this is like a very heavy, it's not heavy in carbs, but just a very heavy fatty meal, and it's actually recommended to have a more carbo-loaded meal the night before an event, just so your body has that sufficient fuel to kind of get through, for example here, the marathon. So just in general, like diet and exercise for athletes, like I said before, just important to load up on carbs, as this is the main fuel that you need. You need to top up all your glycogen stores before an event. You need to also avoid eating too soon. So ideally, we'd just say like have about 3-4 hours of a gap from when you eat to when you're doing exercise, for example. And if any of you guys go to the gym, you'll kind of realize if you go straight after eating, you do start feeling a bit sick and you can't really get through a workout. It's always good to have like a light snack just to kind of top up your fuel. And always remember to like reload everything. And you can always justify going down to McDonald's after going to the gym because you need to reload. I can just see a question here. 1 second. Is diet and exercise high yield? It did come up a little bit, just kind of knowing which bits. So like what can kind of cause fatigue, for example, and I'll be coming on to a little bit here, but I just thought I'd kind of go through the basics here before I build up on it. Okay, just carrying on. So again, protein in moderation, just to maintain your muscle so you don't end up with muscle wasting. avoiding fatty foods, so a roast dinner isn't recommended. Being sufficiently hydrated, so drinking loads of water, ensuring your electrolytes are topped up as well is really important. And also during the event itself, having chill fluids, because your body's going to start overheating from all the exercise you're doing. So having cool fluids going through your system is going to help you cool off inside and prevent you from being overheated. And also like just having regular training, having your rest as well, and just kind of mixing up a bit also helps because it helps work the different muscle groups and the different types of muscle fibers you have and training them. So just quickly going through the different types of fuels. So aerobic respiration, anaerobic respiration, I think we've kind of gone through when we were doing respiratory system. So aerobic respiration is the one that yields the highest amount of ATP. However, it is slow, but it's required for longer duration of workouts. Anaerobic, it's really quick, but it doesn't produce that much ATP. It's more for intense movements. And your phosphocreatinine system, it's super, super quick. Almost you get energy really quickly, but the yield of ATP itself is very, very low. And it's more like quick bursts of energy for about like 10 seconds, for example. With anaerobic, it will go on a bit longer, and your aerobic is for your long duration workouts. Okay. Next bit here, just going through a bit of exercise physiology. So just kind of key bits to remember here is like the acute and chronic changes that occur in your body as it starts to adapt. And chronic changes usually take about 6 weeks to occur. And the key bit to remember here is knowing your VO2 max. For example, this increases, so the amount of oxygen you're able to consume during exercise increases over time with regular training. So you'll find with regular training you start becoming less out of breath. Your cardiac output increases as well, so your blood's pumping around a lot better. Your insulin sensitivity increases, so your body's able to utilize the glucose a lot better. So it's moving it all into your muscle cells. Your blood flows a lot better. You're getting more oxygen going through your body again. Your muscles themselves are building up, getting stronger, learning to actually use your aerobic restoration a lot more, and as it's growing as well. And your liver itself is also kind of getting used to like increasing its glucose uptake, as well as kind of breaking it down to and kind of sending it around the body so you have sufficient amount of fuel. Okay, fatigue is the next bit that you need to know. So the cause of fatigue is usually fuel depletion, and this is very much linked to the reduction in the ATP that's available. And ATP is needed for contraction of the muscles, and without that, and this kind of, it's also needed in your neurons as well. So this is what leads to your muscle strain. So as you have less oxygen, you'll kind of end up producing loads of reactive oxygen species and various other metabolic byproducts. And this causes a lot of damage and interferes with your cross-bridging within the sarcomeres, also affects your anaerobic respiration and your enzyme activity, which kind of eventually leads to this fatigue, and in the case that we had here, collapse. And the other thing it does is it also affects the regulation of your body temperature, leading to overheating because you're unable to sweat and just get rid of that body heat as well. And just linked to that, going on to dehydration. So as we're exercising, we're obviously sweating, and this is why it's really important to keep hydrated, because your plasma volume starts decreasing due to sweat. This then affects your kind of cardiac output, so it kind of reduces the function, increases the strain on your heart. You've got less flow going to your muscles and your skin, which impairs your performance. Then your body temperature starts heating as you're not sweating as much, and that's kind of the mechanism kind of in there, which from dehydration leads to like this overexertion and adds to the reason for collapse. So next question here. So your reg finally leaves you in peace, but Homer starts regaining consciousness, and he tries to waddle over to the box of donuts he's noticed. He calls you over and says that his right ankle is agony, and he tries when he tries to walk. He suggests that you get him some donuts to help ease his pain. You're a little skeptical of his suggestion and give him some painkillers instead and order an x-ray of his foot. What type of injury is he most likely sustained? So I'll open up the polls. If anyone's wondering, that kind of hash thing is basically code for fracture. I'll give it about 10 more seconds. Okay, I'm going to stop the poll there. So there's a bit of a split, but most people have put down E, which is the correct answer, so sprain. So the fact that he's able to waddle around and he's in pain, but he doesn't seem like he's in obvious agony. So it's very unlikely he's actually fractured anything or dislocated anything. So the answer is a sprain. Some of the clues here as well, if you kind of think back, because this is linked to the previous SBA. He's not trained very well and decides to run a marathon, so he's more likely to put more strain. And with the sprain, it can kind of lead to like ruptures and things like that. But in this case, we'll just focus on a sprain. And I'll go on to the different levels of sprains a little bit later on. So just kind of covering some common ankle injuries. I'm not going to go into too much detail, but I have put down pictures and some notes on each one. So just key things to know, looking at the clinical presentation, looking for things like bruising, swelling, any sort of abrasions and cuts. Look at the alignment of the ankle. So this is where it's linked to your ankle exams. For your skis, just check where the positioning is within the joint as well of each of the bones. Look for any tenderness, and just look at the range of motion as well, and see if you can elicit any pain, especially like against resistance, for example, and that will give you clues to if it's a fracture, a dislocation, obviously, or if it's a sprain. And the different views you need to get is your lateral, your AP view, and this thing called the Maltese view, which is basically where you assess the tibia, the malleoli, and the talar bone as well. And this is kind of the joint line of the ankle. And it's this kind of weird, you basically have your leg rotated internally from the hip, so your kind of legs turning inwards about 15 to 20 degrees with the foot just slightly flexed towards you, and this allows you to see the joint line properly to see if there is any like dislocation or possible fracture. And key bit to remember here is looking at the Ottawa Rules. So an X-ray is usually indicated if there's pain in the midfoot with either tenderness in the 5th metatarsal or in the navicular bone. So just on the outside of your foot, if there's any tenderness there, any pain and some radiating pain into the midfoot, then you'll start thinking about things like fractures. Also being unable to weight bear and not being able to walk more than a few steps. And just tenderness around the edges of your kind of medial or lateral malleoli around your ankle. Kind of gives you clues there for any possible fractures or anything like that. So these are, so I've typed up just some of the other types of injuries here, but the main ones I'm going to just go through is these sprains. So your 3 main ones are your inversion, eversion, 2 main ones, inversion, eversion injuries. So inversion, where you turn your ankle inwards, so you rotate it inwards, and the main ligaments which are affected are your anterior talofibula, so ATFL, your calcaneal fibula, and then the posterior talofibula. So you can see your ATFL there, PTFL there, and your CFL there. And the ATFL, this is the most common one that gets damaged. Your eversion injuries, there's just the deltoid ligament there, and this is when you turn your foot outwards, so the inside of your foot is being stretched. And this is quite rare, but it does happen to actually sprain this too. And the way to check this is doing the anterior jaw test, where you try and pull the ankle forward to see if there's any instability there. And very similar to the anterior jaw test that you can do with your knee as well, to look for any kind of ligament injuries there. And just these are just diagrams which I put there just for your own learning as well. Cool. So I think this is the last little bit for this bit. So just going through the different types of sprain and management. So this is your normal ligament. This is your grade 1 sprain, where you've got some stretching, tiny little tears in there. You'll have a bit of pain, a bit of inflammation, but it won't be too bad. Grade 2 sprains, where it's almost like it's torn through, but it's incomplete, so it's still intact. It'll be quite painful. It'll be very inflamed. You'll have a lot of swelling around the joint, but it can kind of scaffold itself. So with ligaments in general, they're usually not very, they don't have a very good vascular supply, but they are able to kind of scaffold itself, which is where the inflammation itself is really useful, because that fluid will kind of provide the nutrients and everything that's needed to help scaffold it. And then your complete tear, your grade 3 sprain, is where it's completely detached from each, the ends are completely detached, and it's not going to be able to repair itself, and you'll probably end up needing surgery for that. So your basic management is RICE, so rest. So avoid weight bearing on the injury. Icing it for about 10 to 20 minutes every few hours for a few days until the swelling's gone down. Keeping it compressed, so like bandaging it, for example, to minimize the swelling, and usually do that for about 1 or 2 days. And then keeping it elevated, so you don't have all the fluid pooling around the joint. The other important thing is just using loads of supports like braces to help maintain that alignment whilst it's kind of healing itself, especially if it's like a grade 2 sprain, where you can kind of self-heal. And pain management is important here, so like NSAIDs and paracetamols, just to help kind of manage the pain so you can kind of function yourself. And just a little note here, NICE guidelines don't really recommend donuts as pain management. Cool. So that's the end of kind of the exercise physiology bit and the ankle. And just a couple of things which I didn't cover there is like the gait cycle and the organization of the muscle pairs and the muscle structure itself, which I kind of just mentioned to look up as you go along. I have put some diagrams in there for it, for your revision too. So if there's not any questions in there, I'm going to move along to the next bit. So can't move my arm. So basically going through shoulders. So we'll start off with an SBA here. So you've got a 26-year-old Phoebe Buffet who's in the middle of an intense tennis match with her evil twin Ursula. She suddenly gets a sharp, intense twinge in her right shoulder and struggles to abduct it because it's so painful. Which muscle has she most likely injured? So I'll open up the polls. I'll give you about 5 more seconds. Okay, I'm going to close the polls now. So it's a bit of a split between A and D. So the correct answer is D. So your supraspinatus is responsible for the abduction of the first 20 degrees. So I always get confused when I hear these. So it's usually quite good to go abduction, adduction to remember the movements. So the other way I remember it is abducting, as in you're trying to abduct something, as in like alien abduction, for example. So taking it away. And then adding, so you're putting it back, so putting it together. So these are the different shoulder movements. I'm not going to go into this in too much detail, but this table is actually very useful. And just put some diagrams in there just to help kind of illustrate what's actually going on as well. But the key movements of the shoulder is your flexion and extension of your shoulder, your abduction and your adduction, and your medial and lateral rotations. And these are things that you will have covered in a little bit more detail during your clinical skill sessions when you're doing the shoulder exam. And the other one is basically a combination of this where you kind of just rotate the whole like circumference of your shoulder. Okay. Now this is the key bit to remember, is the 4 muscles which stabilize the shoulder. So you've got your supraspinatus, which kind of helps elevate the joint itself away from the side. Then your infraspinatus, which helps it rotate the shoulder joint externally. Teres minor is the other one, which helps it also externally rotate. And then your subscapularis, which allows the humerus itself to move freely in the shoulder joint. An easy way to remember this is sits, with your supraspinatus kind of sitting in the front. It's a lot easier to do this in person, where you kind of just show where they sit and with your fingers. But these are the 4 key muscles to remember. And the way I do it is, so my thumb will be the first S, then I-T-S, and just if you sit the thumb in the front kind of groove of your shoulder and then sit the rest around, you'll see where the insertion points are of each of the muscles and where they're sitting. Okay. Next one is another SBA here. So you got 30-year-old Joey Tribbiani. He's out partying one night. The typo there. He's hanging around the bar trying to impress the ladies. He's leaning over the bar stool at the counter using his amazing pickup lines when he suddenly feels his arm go funny. He has some numbness down his arm all the way to his fingers and is unable to extend his wrist or fingers. The girls walk off unimpressed. Which nerve is affected? So open up the polls there. Okay, I'm going to close the poll here because I think everyone's answered very quickly. So the correct answer is the radial nerve. So the radial nerve is basically going around the humerus and then kind of covering the back of your hand going up the arm there. And that's all the extensors of the hand and wrist, with all the whole of the dorsal compartment as well. And this scenario is kind of your classic Saturday night palsy from leaning on a hard surface and compressing the radial nerve, which leads to this kind of paresthesia, which is short term, but it's not very nice either. And typically the symptoms are usually like prickling and numbness that you get here. Key thing to know here is also your brachial plexus. So knowing the course of these different nerves is important. So you've got your radial nerve, just kind of running behind the humerus in the back of the elbow, and just the way you lean on it can lead to that radial nerve palsy there, which is temporary. And the other one is when this usually happens when you're sleeping. If you've got your arm bent, you're sleeping on your arm, you're compressing the ulnar nerve, which runs on the outside of your arm, and you usually get a bit of tingling and numbness just on the ulnar side of your arm down and in your little finger and your ring finger. So this is a lovely diagram which I'm sure everyone loves. So I've put a couple diagrams in here just to kind of illustrate things, but this one I thought was really good just to show the different divisions of that brachial plexus. So here are your roots, so C5, C6, C7, C8 and T1. These roots then go and form the different trunks of the brachial plexus. So you've got your superior, which is a pair, and your inferior, which is a pair, and then the middle, C7, is just kind of left on its own. Eventually what happens is you get these divisions where they cross over. So the way I like to lump it up is C5, C6 and C7 are secretly in cahoots, and they kind of link up with each other, so forming the lateral, and you also have the posterior cord. But then C7 also wants a little help from its inferior buddies, which then forms the rest of the posterior cord here. And then C8 and T1 are just quite independent, happy to help, but they just form their own medial cord. Then with the median branch here, you've got input from the lateral and medial cords, which is basically input from all the roots. Then if you follow this, anything coming off the posterior, you've got the axillary and radial, also has input from all the roots. But then your musculoskeletal is just C5 to C7, and your ulnar is just C8 and T1. This is quite a lot to remember, and I always found it very helpful to remember the order of the muscles, the branches, and then just try and draw out the diagram. I'm quite good at kind of just memorizing the way the lines go, and that's literally how I just did it in the exam to work it out sometimes. So these are your brachial plexus injuries that you need to know. So the two that you will definitely have heard of is the Erb's palsy and your Klumpke's palsy. So I'll just go through herbs first. So this is linked to things like shoulder dystocia during birth. And the classic presentation here is where your shoulder's internally rotated, it's adducted, so stuck to your body, your elbow's extended and your wrist is flexed. And because of the way it's rotated, your hand's basically facing away from you, flexed. So it just looks like this kind of, you're trying to get a tip from behind, which is why it's called the waiter's tip as well. Whereas your clumpies is linked to injuries, from example, like hanging, like and falling from like a position of hanging, because you're stretching out your brachial plexus from underneath, whereas with your Erb's palsy, with shoulder dystocia, you're stretching it out from the top. And that's why you get the different presentation. So with Erb's, you're damaging the top roots, whereas with the clumpies, it's the bottom roots here. And with clumpies, you get this kind of, because it's affecting all the intrinsic muscles of the hand, which is why you get this kind of claw-like look, because your flexors and the wrist and the fingers are just constantly flexed. Then moving on, your radial nerve, any damage to that will be like this wrist drop. Axillary, you'll have this kind of your sensation in your the shoulders affected, and the deltoid, so the regimental patch. And then this is your ape hand, where you're unable to oppose your thumbs. So like apes, where their thumb's not really useful, but you can use your fingers. If you get a lesion here, so this is where it gets a bit confusing. So you have your hand of benediction, and then your pope hand, for example, and then you got your ulnar claw. So with your pope hand, you can't bend your second and third fingers, but you can bend the other ones. And this is really confusing because the diagrams look very similar. Whereas with your ulnar claw, you can't straighten your fourth and fifth digits, but you can straighten your second and third. So just remember, ulnar claw, because it's on the ulnar side, it's a clawing of your last two digits. And I put these basically in the key ones into a nice little diagram here of the damage that causes it, the signs, and just any interventions that might be useful. Okay, and then quickly just moving on to types of nerve injuries. So this is your classification for nerve injuries. So neuropraxia, which is just like this compression or disruption of the nerve supply, which is definitely reversible. So example, compression of the radial nerve, where you have that kind of weird like sensation in your hand, that pins and needles kind of, or like when you're sitting cross-legged, for example, you get that dead leg feeling. But once you stand up, once you get moving, it all disappears. So that's neuropraxia. Axonomesis is a disruption to the axon, but the actual epineuron. So if you look through, there should be a diagram somewhere in my slides where it kind of just labels it. So it's just the amount of damage to the axon itself. So you can see just the outside of the neuron here is still intact. The inner layers are still intact, but there's a bit of damage to the axon itself. And this is usually seen in things like crush injuries, but because it's intact on the outside, it can actually regenerate within itself, similar to like a sprain, a grade 2 sprain, where it's just a partial tear and it can scaffold itself back. Neuromesis is where it's complete severing, and this is something that's almost permanent. And diagnosis with these kind of nerve injuries is like MRI, CT, X-ray are usually quite useful of the shoulder and neck to see if there's any damage which might be causing this and if it's reversible, for example. And just doing nerve conduction studies are the other thing that you can do here. Okay, next question. So you got 31-year-old Ross Geller who tries to prove he is better than his sister Monica in a tag football game with his friends. He charges into her, speedily aiming to knock her over. He falls to the ground in agony. His shoulder looks funny, and he is unable to move his arm. It looks like he's dislocated his shoulder. What type of dislocation would be more likely to occur in this scenario? I'll open up the polls. And give it about 10 more seconds. Okay, I'm going to close the polls now. So it's a split between C and D, and the correct answer is C. So posterior dislocation, and posterior dislocations are common in these kind of scenarios where the mechanism is kind of you force yourself into someone, basically pushing your shoulder back, which leads to that posterior dislocation. Anterior dislocations actually are the most common type of shoulder dislocations, and it accounts for about 95% of the cases. So this is because the top of the humerus is easily displaced towards the front of the body than it is towards the back of the body, and this is usually just typically a sports injury. And in older people as well, it happens because they kind of the way they fall down with their arm outstretched. Posterior dislocations is like similar to these kind of like kind of sporty, like rugby, for example, where you physically push your shoulder back. This is about 2 to 4% of all shoulder dislocations. It's also related to things like seizures or electric shock, because in these kind of scenarios, you'll have a mechanism which causes the humerus to be displaced backwards. And then inferior shoulder dislocations. So this here is very, very, very rare, but this is where the humerus gets displaced downwards, and this is more related to specific mechanisms in trauma, and it would require a specific type of movement and quite a lot of violent movement going to push it down. Aside from like things like trauma causing dislocations, other things are overused repetitive straining, especially of the muscle groups which are basically stabilizing your joint, and the loss of the capsular ligament itself. And then just going through your clinical presentation, so your classic ones are your malformation of the joint, swelling, bruising, kind of immobility, intense pain, and any sort of tingling, numbness in the neck and arms. Risk factors, which I've briefly gone through, so sporting injuries, so usually like young, fit people. If you have any nerve injuries or any family history of lax joints or hypermobility yourself, and any Bankart lesions. And this is basically where you have lesion of that kind of labrum here within the glenohumeral joint, which makes it a lot more lax in there. And your investigations are your X-rays, CT, MRI, and in some cases actually ultrasound is quite useful as well. And Bankart lesions again is very much a complication as well as a cause for it. And you can also have a Hill-Sachs injury, which is the compression fraction within the humerus, which can cause even more pain. I think this is the last SBA. So Ross rushed off to A&E. He is in severe pain and is begging for some painkillers. A&E Reg assesses Ross and decides that he needs a close reduction. The Reg decides to quiz you on the type of analgesia to give in this scenario. Which would be the best analgesia to give Ross? So I'll open up the polls. Give it about 10 more seconds. Okay, so I'm going to close the polls now. So a bit of a split between B, C, and E. So the correct answer is E. So midazolam, just kind of going over some of the others. In a dislocation, especially if you imagine you're going to do a closed reduction where you're going to yank the joint back into place, is going to cause a lot of pain. And I don't know if anyone's had any injuries or not. Paracetamol and ibuprofen are not going to touch it. Morphine will, so will oxycodone. But the best thing in this case is midazolam because it makes him drowsy, gets rid of the anxiety as well, especially before like things like surgery or any other procedures. It also has an element of amnesia, so you're not going to remember that pain. So you won't be traumatized, for example. So in this case, that's the best one to give, especially when you're going to do something as invasive as pushing your joint back in. And the key reason is just the amnesia and the calming effect, and it just relaxes all the muscles around. And it's a lot easier to fix any joint issues if the patient's sedated compared to when they're awake. So just imagine having surgery, you don't want to be awake for it. So that's why you get the answers midazolam. And then just a quick slide on management of shoulder dislocations. So pain relief is the main thing, and post-reduction you can give your NSAIDs, paracetamols and codeine add-on if you need, and then maybe consider things which are stronger if it's really needed. Following the reduction, you need to make sure that you immobilize the joint just to allow it to kind of settle. And it's usually up to about 3 weeks where they'll probably just walk around in a sling. And you do need to keep it active, but with gentle movements to ensure that you still have that range of movement there. Otherwise it becomes stiff. And then just any kind of management to prevent reoccurrence. Physiotherapy is a great thing, and any traumatic instability, for example, or any other kind of reasons you might want to consider like surgical intervention as well. The only downside with surgery is your joint will never be the same again. There'll always be some tightness or some limited movement within that joint after surgery. And then just I put in just because sometimes you might get a very niche question and you just might want that extra mark in your exams. Just side effects of midazolam, so headaches, nausea, vomiting, cough, drowsiness, and you can get over sedation as well. And you can get this sort of swelling, redness and stiffness at the injection site, and a lot of tenderness too. Cool. I think that's the last one. So thank you guys for listening. Just a couple things which I didn't cover. So like soft tissue injury and like the basic process of the injury itself and the healing. Side effects of the other analgesics as well. And then just the actual elbow joint itself. I didn't go through here, but yeah, that's all from me. Any questions?
My name's Anaya. I'm one of the F1 doctors at George's, and I'm going to be running through psoriasis. So we're going to start by talking through the anatomy and function of the skin. So in terms of the functions, there's a mnemonic, which is shapes, which I used to use to remember. So S is for sensation, H for heat regulation, A for absorption, P for protection, E for excretion, and S for secretion. Now I always muddle up excretion and secretion, but excretion is getting rid of waste products, and secretion is secreting, like in the skin, oils and things that are useful for the function of the skin. And looking at the anatomy of the skin, you've got the dermis, which is the portion of the skin where you've got all your like hair follicles, your nerves, your arteries, your veins, sweat glands, things like that. And then the very top layer is the epidermis. And that layer consists of 5 different layers that it's worth remembering. And at the bottom, you've got your stratum basale, then you've got stratum spinosum above, then granulosum, then the stratum lucidum, which is actually only present in kind of the thicker parts of your skin. So like the soles of your feet and the palms of your hands have the stratum lucidum, other parts don't. And then the top layer is your stratum corneum. And your keratinocytes, so your skin cells, are made in your stratum basale, and then they progress upwards as they mature through the different layers. And as they mature, they kind of go from being these square shapes to flatter, and like flatter scales, and they also lose their nucleus as well. So as they mature, it's like this cycle of going up and then getting like sloughed off at the top of the surface at the stratum corneum. So first SBA, how would you describe these lesions? I'm going to open the poll now. Just going to refresh. I don't think that opened. 1 second. Try again. There we go. It's open now. So are they nodules, vesicles, macules, papules, or bulla? I appreciate it's a bit hard to tell from this photo, but some of you might know kind of what disease it is, which might help. Going to give it 5 more seconds. All right. So the correct answer is actually B. We had a split between A and D on the poll, but the correct answer is B. So this is a photograph of what all the different kind of ones to know look like. I wouldn't worry too much about it, and unless you're a dermatologist, even doctors seem to get this wrong all the time. And realistically, in hospital, if you see something wrong with the skin, people tend to just refer straight on to dermatology. But for GP, it's definitely worth knowing. So running through why the one before was vesicles. So they were, if you look in the picture, they're these kind of little lesions that are filled with fluid, less than 1 centimetre. So that's why they're vesicles. A lot of you put papules, but they're actually solid lesions. So that's why that answer was wrong. And I can't remember what other people put. But yeah, just it's worth just looking at this table and just knowing what each of the descriptions look like. And the disease in this was shingles, was what I was going for. So chronic plaque psoriasis is a chronic skin disorder that affects around 2% of people in the UK, so it's really common. It has different degrees of severity for different people, but overall it's really common. You get these clearly defined red plaques with a silvery scale. Exam questions love mentioning the silvery scale as well. And the most common sites for psoriasis are the scalp, elbows, and the knees. So it's on the extensor surfaces, which is a good way to differentiate between psoriasis and eczema, because eczema tends to be flexural, whereas plaques like psoriasis tends to be the extensor surfaces. And in terms of the pathogenesis, it's not fully really understood, and I definitely wouldn't worry about it for GEP 1, but just know that you get this overstimulation of immune cells, and you get this chronic state of inflammation, and it causes this excessive proliferation of the keratinocytes that aren't really maturing correctly. So normally that cycle I was talking about from the stratum basale in the epidermis up to the stratum corneum at the top, normally that takes 3 to 4 weeks, but in psoriasis that process is really sped up, and it only takes about 3 to 7 days for a keratinocyte to go from that bottom layer all the way up to the top and be shed off the surface. So SPA2, which of these is a genetic factor linked to psoriasis? All right, I think most of you have voted now, so I'm going to stop the poll. So the answer is HLA-CW6. I wouldn't worry too much about these, but they're quite good, just easy 1-marker questions that if you know the answer, it's good to just know. And HLA-CW6 is the one that's most commonly associated with psoriasis. There are a few others as well that I've put at the bottom, but CW6 is the main one to remember. So SPA3, which of the following nail changes is least likely to occur in psoriasis? So the poll is open now. So is it pitting, onycholysis, subungual, hyperkeratosis, crumbling, or koilonychia? Can I give it another few seconds? I think we have, one person left to vote. All right, everyone has voted, so I'm going to stop the poll. So the answer is koilonychia, and you've probably heard of koilonychia because it's the spooning of the nails that you get with iron deficiency. But all the others are signs of psoriasis. So pitting, you get these little kind of dots on the top of the nail. Leukonychia, you get these little white marks on the top. Crumbling is crumbling of the nail. Subungual hyperkeratosis is where it's really thickened at the end of the nail. Onycholysis is where the nail is kind of coming away from the skin. And then splinter hemorrhages, which you might have heard of because they're associated with infective endocarditis as well. But they're also associated with psoriasis. So the only one in the question before that isn't is the koilonychia, which is more to do with iron deficiency. So some of the associated features to do with psoriasis. So nail changes are really common. They're present in around half of the cases. And then psoriatic arthritis you might have heard of. That's also quite common, where you get these stiff, kind of painful joints, often in the knees, ankles, hands and the feet as well. And psychological distress is really, really common in psoriasis. I don't know if you still have, on the course we used to do a trip where we'd go and speak to patients who have psoriasis. And like it was one of the kind of recurring themes is how much stigma there is around psoriasis, because their skin is flaking off all the time and people can be quite cruel about it actually. So it's just really important to remember if you ever kind of meet someone with psoriasis. And there are lots of different triggers for psoriasis. So different things that can cause a flare-up of the disease. And so obesity, smoking, alcohol, stress, injuries. So sometimes if they get kind of sunburnt or a cut, you can get something called covanized psoriasis. Sun exposure is usually beneficial. It's something that most doctors will encourage their patients to go outside and get some exposure to the sun because it helps, but for some people it can actually go the opposite way. Medications, so the most common ones to know about: lithium, beta blockers, antimalarials and NSAIDs are also best to avoid in psoriasis, and stopping steroid medication can also cause a flare-up. So next SBA, a 35-year-old gentleman comes into the GP surgery complaining of a new rash over his trunk and limbs. On examination, you notice a shower of small, red, scaly, teardrop-shaped papules. He tells you that the rash came on quickly over a few days and that he was suffering from a sore throat 2 weeks ago. Which type of psoriasis do you suspect that he has? So A, small plaque psoriasis, B, chronic plaque psoriasis, C, unstable plaque psoriasis, D, erythrodermic psoriasis, or E, guttate psoriasis. Gonna give it 5 more seconds. All right, I'm gonna close the poll now. So the answer was guttate psoriasis. So in guttate psoriasis, you get what looks like this photo here, where it's usually kind of all over the back and the trunk, back in the limb, sorry, and they look like kind of teardrops. And in 80% of cases, it's following a sore throat. So that's one of the key giveaway things in an exam question. Most cases, it will spontaneously just resolve by itself. And in some cases, like rarely, it can go on to become chronic plaque psoriasis. But most cases, it's just self-resolving in a couple of weeks. So yeah, chronic plaque psoriasis is the type that we spoke about earlier that you're probably most familiar with. Then you've got this guttate psoriasis, which is followed by a sore throat, usually a streptococcal infection. Then flexural psoriasis is a bit rarer, and that occurs on the flexural surfaces instead of the extensor surfaces. So that's the top photo here. And instead of having this like scaly raised appearance, it's kind of smooth and a bit shinier. And then pustular psoriasis, which is quite rare, I wouldn't really worry about, but you get these pustules, particularly on the palms of the feet, on the palms of the hands, sorry, and soles of the feet, on this background of really red skin. So management of chronic plaque psoriasis. So first thing to know about, first line, is topical therapy. So usually you prescribe a corticosteroid and then a vitamin D analog. Second line, if there's no improvement with that, then you'd offer vitamin D analog twice daily. So again, that's a topical treatment, and like calcitriol is a vitamin D analog. There are a couple of others as well. And then third line, you can do corticosteroid twice daily and then coal tar. That's really not very popular because it gets on people's clothes and it's just not very pleasant, smells a bit weird as well. Then second line of management, you can use phototherapy. So UVB is now the treatment of choice, but you might have also heard of PUVA, which is Sorolin and UVA. And the UV, what it does is it kind of slows down DNA replication, so it kind of stops that proliferation of keratinocytes. But the adverse effects are that it causes skin aging, and it can also cause, put you at increased risk of cancers. And then third line is systemic therapy. So oral methotrexate is the first line. And to be honest, I wouldn't really worry about the rest, but you can use biologics, or like retinoids and things. But methotrexate is the first line. I doubt they'll ask you about management, but just so that you are aware. The slides are not moving. So we're coming to the end now, but just a slide on eczema, because that's the other main condition to know for this week. So I'm sure probably lots of you had eczema as a child. It's really common. You get this dry, cracked, itchy rash in the, it's usually in the flexural surfaces in children and adults, but in infants and babies, it's actually on the extensor surfaces. But as you grow older, it becomes more common in the flexural surfaces. It affects 10 to 30% of children and 2 to 10% of adults. And there are specific triggers for it. So things like perfumes, different detergents, soaps, clothes, food. It's different for different people. But yeah, really common and yeah, just important to be aware of. And that is the end. So this is I put the QR code for the feedback. So if you do have to head off early, thank you for coming, and just if you could fill in the feedback, we'd be really grateful. And if not, if there are any questions, let me just shut this.
So we're going to go through osteoarthritis and rheumatoid arthritis. Okay, just the important, there's a few concepts just to get your head around, and then I think it's pretty easy after that. Actually, we have three pictures here: the healthy joint, osteoarthritis, and rheumatoid arthritis. When you're looking between the osteoarthritis and rheumatoid arthritis joints, you will notice that there's a much more significant inflammatory process happening in the rheumatoid arthritis. And you can see it's quite reddened, the joint space, the gap between the bones, that's, kind of increased. The inflammation is kind of pushed kind of bones apart a little bit and increase that space overall. But the main thing is rheumatoid arthritis is an inflammatory arthritis. So the arthritis comes as a consequence of inflammation. When you look at osteoarthritis, it's that term of wear and tear. So you have like cartilage that lines the bones and a bit of synovial fluid. It can be due to age. It can be due to a little bit of genetic predisposition. It can be due to just wear and tear. But that synovial fluid kind of decreases over time, and the cartilage that lines the bone kind of wears down, and you end up with bone and bone contact. When you get the bone and bone contact, that rubbing, that damage to the bone, that results in secondary inflammation. So the inflammation is more of a consequence of the bone and bone rubbing, but it's the fact that there's a reduction in kind of cartilage, synovial fluid that's causing it. In contrast, rheumatoid arthritis is caused by inflammation. Inflammation is not a consequence of it. So that's the main concept to get yourself around. And the reason that's important is you may have come across the cardinal signs of inflammation. And those are some of the clinical features you see in inflammatory arthritis, such as rheumatoid. So I think I may have, okay. So There's rubor, which means the kind of redness. Calor, which is means heat or warmth. Dolor, which is for pain, and loss of function. So I think that's the Latin derived words to can explain some of the observations you see with inflammation. So a patient with rheumatoid arthritis, the joints may be warm. There might be some slight reddening of the skin, depending on the complexion, and there'll be a loss of function because you've increased the joint space. You've put kind of a lot of stress onto the surrounding structures and this pain. They also might have some systemic features. So when we look at, if anyone comes in with some joint pain, you need to kind of have a little system in thinking, okay, is this joint pain arthritis? Is there osteoarthritis? Is there rheumatoid arthritis? Is it something else? And a nice category to put it into is, okay, is this an inflammatory or non-inflammatory? So we talked about the signs of inflammatory arthritis, that warmth, redness, kind of swelling of the joint. And that's all linked to inflammatory things. Osteoarthritis, you wouldn't expect to see that. Yeah. The other thing is, in septic arthritis and a few other things, if there's inflammation occurring, rheumatoid arthritis also has systemic features. So they may have other systemic features along with the arthritis. In septic arthritis, they may have high fevers. They may kind of be quite sick and poorly. With gout, it's usually just one joint affected. They might have maybe deranged liver function, kidney function, and things like that. Whereas you wouldn't expect that in someone with osteoarthritis. This is due to wear and tear. It's not due to an infection. It's not due to poor kidney function or liver function. This is just to do with the mechanics of joint degeneration and bone rubbing on bone. Yeah. Okay, so osteoarthritis is the degeneration of a joint complex. Now, its clinical characterization has features such as joint stiffness, joint pain, and functional limitation. That is helpful, but sometimes a bit difficult because the main aim of the game today is to be able to differentiate an osteoarthritis from a rheumatoid arthritis and possibly from other kind of causes of inflammatory arthritis. So you could argue that you see these same characterizations in rheumatoid arthritis. So then we can look at these clinical features, and these sort of help us differentiate inflammatory from non-inflammatory. So with osteoarthritis, it gets worse with activity and better with rest, because as there's an increase in activity, there's more bone-in-bone articulation. That's increasing the pain, driving inflammation. It makes things worse. With inflammatory arthritis, when you start moving that joint around, that fluid built up, but as you start moving it around, you're actually squeezing the fluid back out into the vasculature and draining some of the fluid away. And therefore, there's less pressure in those joint spaces. So the symptoms tend to actually improve with activity. So that's one key differential here. Remember the others that we talked about, systemic features. If there's systemic features, osteoarthritis, that doesn't classically give you systemic features. So you need to be able to consider other differentials. Now, these crepitus, so if people aren't kind of familiar with that, it's basically either a palpable or audible noise of kind of vibration when the joint is moving. And that crepitus is quite common in arthritis. And also tenderness. So when I say tenderness, say if someone's got arthritis in the knee, if you are to kind of put some pressure along the joint line, just with your hand, just palpating the joint line of the knee, there will be tenderness. Tenderness and crepitus are actually two of the most common clinical findings in osteoarthritis. So the kind of patient telling you is worse for activity, better with rest, yes, but on examination, tenderness and crepitus are very, very sensitive for osteoarthritis. Also, you don't really see crepitus in rheumatoid arthritis. It's another kind of differential there. Crepitus is caused by the bone and bone rubbing. That's what you're either feeling or sometimes even hearing. And pain, inflection, and extension. Why is that important? This is a good way to kind of differentiate maybe if someone says they're pain in the knee, there's a lot of musculature around it as well. And if there's pain throughout the whole movement, so going from full extension into extension, that kind of weighs a bit more to do with the kind of bone element. If there's pain just in flexion and not in extension, that may lean you towards more muscles or other causes. But also arthritis, the entire joint is affected. It's not just that the joint is affected in certain parts of the movement. So if it's pain throughout the movement, you can start to think about it's probably some bone involvement as well. Now, and so risk factors for it. Okay, your modifiable weight, particularly obesity and excessive joint loading. What that means simply is, if someone's, maybe someone goes to the gym and they're doing excessive kind of weight training, or someone's doing long distance running, but maybe on a kind of tarmac or concrete kind of paving, they're repeatedly putting a lot of strain through the joints. So that can be adapted, that can be changed a little bit. If someone's obese, there's more force, more weight that joint will have to carry or support. So those are modifiable risk factors. The non-modifiable: age, gender, history of joint trauma, and asymmetric joint loading. So age, as we get older, muscles get weaker, bones become less dense. There is more wear and tear, cartilage breaks down. Gender, there seems to be a slightly higher predisposition in females, and it's, there's some kind of evidence to suggest it's a change in kind of estrogen levels that can contribute partly to this. Coming on to history of joint trauma, essentially, if someone's had surgery such as ACL surgery or previous fracture, even with surgical repairs, a lot of the times things don't go back to 100%. So this is evidenced by, I think they took a kind of retrospective study of people that have had ACL surgery, and they found that the onset of kind of osteoarthritis in the knees would actually be at least 1 year earlier in the knee that's had the ACL surgery when compared to the other knee. And that's because when you do the repair, you do alter the mechanics. So the body's built, almost in its optimal form of shock absorption, movement, and kind of pressure distribution. So even when we do a surgical repair, we might not get back to 100% optimal in terms of how weight is distributed and shock absorption occurs. So there are slightly higher risk of actually developing osteoarthritis, because inevitably that joint is going to have to kind of be exposed to a bit more joint force or kind of asymmetric joint loading, and therefore that kind of puts them at risk for things like joint degeneration, osteoarthritis. So that's your non-modifiable. Another slightly modifiable thing is with any joint. So if you think about the knee, as you get older, we've talked about things, getting weaker, bones, kind of mineral density. But a modifiable thing people can do is some strengthening exercises. So if it's the knee joint, you strengthen the muscles around the knee joint and they help support the joint. So they can take some of the force and they can help support some of the bones in their movement. And that will reduce your chance of, developing osteoarthritis, or at least slow down its progression. So certain exercises, physiotherapy, that can definitely help with osteoarthritis. Now, this is something you guys should know. It's most certainly going to come up in your exams, and it will be throughout medical school. It's one of the nice things. It's got quite a simple mnemonic called loss. And the L stands for loss of joint space. So when we discussed it earlier, it's your kind of decrease of synovial fluid, the kind of cartilage wearing down between the joints. So you get a narrowing or loss of joint space. That's the L. You then get something called osteophytes. So osteophytes, they occur due to bone on bone kind of rubbing or damage. So when bones rub on each other, there's some localized inflammation, and over time, these little bony spurs form, and these are called osteophytes. The sclerosis that you see is that kind of bright white line, and sclerosis just means hardening. If you think about it, it's the very tips of each bone that are in contact with one another, and they're rubbing. And what tends to happen is this rubbing, it's causing that micro trauma at the very ends of the bone. And what the bone does in response to this is it increases the bone mineral density in that area, because it knows it's getting kind of damage in those areas. So it increases the bone mineral density to compensate for this. And that increase in density is why it shows up as bright white on the X-ray. And that's called sclerosis. Sclerosis in any format just means hardening. And then lastly, you get the cyst formation, and it's sometimes fluid filled. And part of the reason we get cyst formation is because the ends of the bones are increasing in their mineral density. So some of the kind of bone cells, so it's the osteoblasts that kind of help build new bone. They kind of move towards the tips of the bone, and that's, they cluster, and that's why we see this kind of dense white. But as they move to the tip, the areas behind it are less dense with bone cells, and sometimes they can become fluid filled, and we form this kind of osteocytes, which are basically cysts within the bones. So that's the explanation of the lost mnemonic. But it's really important because, when we look at an X-ray and we think osteoarthritis, we just say yes, we just kind of reel off all these features. But a lot of times you may see cyst formation and nothing else. So it's really important to kind of understand why each one is happening and to be able to recognize it well. It will come up in exams. It will be present throughout your careers. It's something pretty, I think, in terms of radiography and stuff, it's one of the nice ones to be able to learn. So just learn it well. Investigations and management. So with osteoarthritis, the main thing is get an X-ray of the affected joint, because it is a clinical diagnosis. You can't do a test for it, but if we look at the knee, for example, or the wrist, whatever, you need an X-ray. You need to see if these features are present. Put that towards your clinical examination and history. That's how you can present the diagnosis of osteoarthritis. So you want an X-ray, and often you want two different views of that joint. You also do your inflammatory markers, so CRP and ESR, and that helps you to know, because osteoarthritis is one of the consequences of inflammation, you know how bad is the inflammation. If the markers are really massively high, like off the charts, you may not think, you might start to think, wait, this might be inflammatory driven as opposed to kind of wear and tear. Your inflammatory markers will be raised, but they won't be skyrocketing. So that's the key things for investigations and management. So, investigations. So with management, there's many steps to this. I think at this stage, you just need to know the first line, and that's topical analgesia, and that's usually in the form of like a capsaicin cream or Voltarol gel. So that can be applied directly over the joint, because the elbow joint, the knee joint, the shoulder joint to some extent, they're quite superficial joints. So topical analgesia in the form of creams or lotions, they act really well. The hip is slightly different. It's a bit of a deeper joint, and it's covered by a lot of muscle. So you still try topical, but it might not be as effective. And we've got physiotherapy there because, again, if you strengthen the muscles around that joint, it helps compensate for the kind of joint's vulnerability, because worn and torn and some of the degeneration. And you can also consider corticosteroid injections. And what the corticosteroid injections would do is they will dampen down the inflammation within that joint, which is great for the pain relief, but you still have the process of bone and bone rubbing, that wear and tear, that's still ongoing. The effects of corticosteroid injection, they may work for a few months for some people, it may work, maybe a month for others, but they have found that, I think it's more than 2 or 3 injections in a year, the benefit actually provides the patient, it starts to decrease. They start to become almost not immune to it, sorry, but they become less, the benefit is less noticeable to your patients. And you don't want to do too many, because if there's a long waiting list, they don't quite fulfill the criteria to get knee replacement or hip replacement surgery, your kind of pain management options are very short then. So use the corticosteroid injection sparingly. And with anything, lifestyle adjustments. So, just right off the bat, do you think this person could benefit from losing some weight? That's one thing. It could be, say for example, if your patient is a builder, you might question, can they adapt their job in any way? Can their day-to-day routine be adapted in a way that would put in less stress on that particular joint? And things like that. Yeah. So lifestyle adjustments. But the main thing is, first line is a topical analgesia with physiotherapy, with consideration of corticosteroid injections. So it's not an oral tablet. It's not physiotherapy alone. It's topical analgesia with physiotherapy. Okay. Ooh, I think it's a bit of quiz time. So
The poll's open. Should we give it 5 more seconds?
Cool.
All right, I'm going to shut the poll now.
Cool. Thank you.
Nice.
Yeah, so that's the lunate vote. So yeah, there's a nice little mnemonic here. So if we start with scaphoid and you go across, you can say straight line to pinky, and then here comes the thumb. So that's a mnemonic. You can learn it how you wish. I think one thing to really, really appreciate here, and if you're looking, you're not quite sure to get your orientation, is if you stick out your hand and you spread your fingers, you notice just behind your thumb, like almost a little dimple appears. Kind of looks like a triangle, and that's called the anatomical snuff box. Little kind of detour into history. People that used to kind of sniff tobacco or something, they would use that little dimple in their hand to place the tobacco and kind of sniff it or whatever. And that's why you got the term anatomical snuff box. In the current day, that's important for us because if there's pain over the anatomical snuff box, it's quite sensitive for a scaphoid fracture. So often what you hear is someone that falls with their hand outstretched, almost like, they're trying to give a high five or something. The hand outstretched hits the floor, develop pain in that kind of area. So if you touch the anatomical snuff box and they report pain, you need to make a consideration for a scaphoid fracture. So if you're thinking, my orientation, you think that's your scaphoid underneath the anatomical snuff box, and just above it, you can't really press, but you've got your I think you can sort of feel it if you press down. You can feel your scaphoid there. So you can use these mnemonics. Just make sure you can feel your hook of hamate as well. If you press down, you can kind of feel the nook. So it is good to it's good to be orientated with the hand and also really know where the carpal bones are. Okay, so moving on. Okay, so and now it's probably becomes a bit more apparent when you look at hand X-rays and things. Just knowing your carpal bones, knowing the orientation. So what we have here is an X-ray of a hand. So there's 5 options. Take a moment, think about it. Not just answering the question, but also see if what your option is, if you can really see that in the X-ray. We'll give you a little bit more time. Okay. Nia, is that enough people have responded to the poll?
Yeah, I'll stop the poll now.
All right. So this one does have all of the features of loss. And for those that aren't able to kind of really decipher it, so here, so if you look, so it's the same one, it's just been kind of stretched out. But so if we take a quick look at this, and go back, so you can see the bright white area just under the thumb. That's your kind of sclerosis. That's your hardening, the increased bone density. That's why it's white. And if you look to the side of it, so the kind of most lateral portion, you can see there's a kind of so what's red here in the red dot. If you look back, so that would be your osteophyte. So you can see how there's a decrease in bone density there, maybe slightly fluid filled. So you can see that. And of course, the bones are touching. So even if you weren't sure of kind of how much joint space, but here the bones are touching. So there's a loss of joint space. And and it's not really here, but further up, if you're looking at the first kind of interdigit joint, you can see there's like a subchondral cyst as well. Okay, so those are the features of loss just on a hand X-ray as well, but this will definitely come up in the exam. One technique I was told is some things are quite evident, but also look around at the rest of the hand. So, you know, look up each finger, looking at the interphalangeal joints. So you can see even here at the wrist between the carpal bones, there a little bit of sclerosis, and there's some joint narrowing as well. So even though if he hasn't fully fulfilled the criteria, you can see some early changes as well, just between the radial bone and some of the carpal bones. Okay, so moving on to rheumatoid arthritis. So as we said earlier, it's an inflammatory arthritis. It's an inflammatory condition. It's probably the most common inflammatory arthritis seen by doctors around. And again, this is a condition that's a clinical diagnosis, and I really want to highlight that it's a clinical diagnosis. We're going to talk about some of the really useful markers for rheumatoid arthritis, even though they have high sensitivity, specificity. In a large percentage of people, they're absent, and that's why it's a clinical diagnosis. All right, so these are the things I mentioned earlier regarding your cardinal signs of inflammation. And not that you need to kind of know the Latin for it, but when you're examining a joint, if it's red, there's swelling, it's warm, patient reports pain, a loss of function, you can start to think, okay, there's some inflammation, and then it's all about your questioning, like, how is it first thing in the morning? So, once they've woken up, they say it's really bad. Okay, but, it takes me a little bit of time, but say after 30 minutes of kind of moving around, that it improves. So you think, okay, this inflammation that I can feel evidently patients reporting, it's getting better with activity. You think that sounds more like inflammatory arthritis, not an osteoarthritis. Okay, so rheumatoid arthritis can also have lots of extra-articular manifestations. So it can affect the lungs, the eyes, the skin, all over. So if you say you're on the wards, either this year, next year, you encounter a patient GP. If you want to be really slick, if your patient tells you, they have rheumatoid arthritis, so it's diagnosed, you need to get in the habit of doing kind of a rheumatology review of them. So checking the eyes, lungs, skin changes, and in particular skin, because psoriatic arthritis is another differential for inflammatory arthritis. So it's good to ask about skin changes as well, because rheumatoid arthritis, psoriatic arthritis may not be the easiest things to differentiate. Okay. So again, I said the main takeaway thing from today is to be able to compare and contrast osteoarthritis from rheumatoid arthritis. There are some features: pain, swelling, redness, warmth. But I think the main thing is, okay, so the activity. If the pain changes the activity, does it get better, does it get worse? Another thing is osteoarthritis tends to be kind of asymmetrical. Why is that? Because it depends on joint loading. If people are right-handed and they work in a manual job or something, it's going to be their right hand that they use more. If they're maybe a football player and they've injured the right leg, and that's what's had surgery, all these things are asymmetrical. Whereas rheumatoid arthritis, it's an inflammatory condition. It's kind of systemic. It's going to affect both sides kind of symmetrically, right? So osteoarthritis might be the right hip is really in pain, or the right knee, or even the right shoulder. Whereas rheumatoid, it's going to be both sides and multiple joints. Yeah. A really common thing that comes up is, a differential is rheumatoid arthritis doesn't affect your distal interphalangeal joints, whereas osteoarthritis does. Now, the reason for this is in your distal interphalangeal joints, there's very, very little synovial fluid. Rheumatoid arthritis affects things through inflammation, and the synovial fluid, some of the proteins found in it is linked in the chain of inflammatory reaction of rheumatoid arthritis. But there's very minimal synovial fluid present in the distal interphalangeal joint. And therefore, you don't tend to see rheumatoid arthritis occurring there as much, but mostly in osteoarthritis. But it's not a hard and fast rule. In the textbooks, yes, but there is some crossover. But for you, exam mode, that's a key tip to sway you to osteoarthritis as opposed to rheumatoid. So think about symmetry, think about multiple joints, think about how it changes with activity, any constitutional, have you got fever, is there a family history of like autoimmune conditions, things like that. So all those things you need to make considerations for when you're differentiating these two. All right, another question for you guys. So Mrs. A is a 36-year-old lady who presents to GP with pain in the small joints of her hands. After taking a thorough history, the GP decides that she is likely to have an inflammatory arthritis. Which of the following is least consistent with a diagnosis of rheumatoid arthritis? Okay, I think I'm just going to change the next slide. So we just discussed it. Yeah, it's the distal interphalangeal joints being affected. Like I said, it's not hard and fast rule, but when you look at the other options, this definitely the one that's going to be least consistent. Pain is much worse in the morning or after rest for people with inflammatory arthritis because the fluid builds up within the joints, exerts pressure that that translates as pain and loss of function. Morning stiffness is the same principle, swelling of the joints, and symptoms exacerbated by rest. So rheumatoid arthritis is actually a really, really debilitating condition if left untreated. You can see the image there clearly. It causes huge structural damage, bony deformities. There's a complete loss of function. I think there's I think it's a New Zealand a brilliant hand doctor there, and he said if someone's hand was someone's thumb, just a thumb, was to be removed, about 70% of upper limb function has been basically knocked out. And if you think about it, your arm, the shoulder socket, it's just placing your hand in places for your hand to actually, do the fine motor movements. But your actual arm is just kind of moving, directing your hand around. With that, if you take off your thumb, you lose about 70% of all function. So when you translate that to someone with rheumatoid arthritis and you look at some of the deformities, it's hugely debilitating. And it's something that's preventable if it's diagnosed and managed in good time. So that's really, really, really important. with osteoarthritis, knee degeneration, you could do knee replacement and such. Rheumatoid arthritis, once that bone damage, erosion occurs, there is surgical options, but it's nowhere as effective. So it's something you really want to treat quickly and take quite seriously. So these are some of the signs and some of the manifestations you can see. So coming on to investigations. So like I said, it's a clinical diagnosis. You don't need to have these present, but they often do help with support diagnosis. Rheumatoid factor is frequently seen in rheumatoid arthritis, but it's also seen in other conditions. Hepatitis C, other rheumatological conditions, I think Sjögren's syndrome, I think Beckett's as well. And approximately about 30% of people with rheumatoid arthritis are negative for rheumatoid factor. 30%, that's almost 1 in 3 patients. So that's quite a high number. This would just be negative. But rheumatoid factor is quite sensitive. It is quite sensitive for rheumatoid arthritis. Whereas when we look at anti-CCP, it's very specific for rheumatoid arthritis. It's got moderate sensitivity, but it's very specific. It's about 90%. Again, however, it's only positive in about 70% of patients with rheumatoid arthritis. So again, 30% of patients, it can be negative, and they still have rheumatoid arthritis. So that's why often they will combine, you won't just send anti-CCP as a single test, you would combine rheumatoid factor and anti-CCP, and that often helps to kind of, you're getting specificity and sensitivity kind of boosted when you kind of use multiple tests there. And finally, anti-nuclear antibody. Now, this isn't often done because anti-nuclear antibody is basically present in the majority of autoimmune conditions. It's not specific at all. So, you would have that in SLE, you have it in Sjögren's, you'd have it in basically most autoimmune conditions. It is present in about 30 to 50% of patients with rheumatoid arthritis. Again, because it's not specific, it's not as helpful. If you're making a clinical diagnosis and maybe anti-CCP and rheumatoid factor haven't shown up positive, this helps support your diagnosis, but in no way does it kind of, a positive ANA doesn't translate to a biological diagnosis. It just helps support it from the clinical history. The clinical exam findings might be, you're starting to see some of these deformities. So it's an adjunct. Okay. The other investigations, again, sorry, you want to get an X-ray of the joint because you also the management of rheumatoid arthritis is very, very different to that of osteoarthritis. So you want to get an X-ray. You may not see many changes of rheumatoid arthritis in the X-rays, but it may help you exclude things like osteoarthritis. You're looking to see if there's the joint space, how that's being maintained, like that. You need to start these patients on something called DMARDs, so disease-modifying anti-inflammatory drugs. Now, they're great. They do come with a lot of side effects. A lot of them will have kind of side effects on the liver, on the retina, on the eyes. A lot of them have skin manifestations. So if you if you're in primary care settings and you diagnose a patient, you suspect a patient has it and the blood tests are showing that way, when you refer them to secondary care, you can still order full blood count, liver function, if it's possible, maybe a review from the optometrist, just as all these baseline tests, because to start them on any medication, you need their baseline, because the risk benefit is if you sort of have to treat them aggressively to make sure their joints don't kind of endure the kind of deformity and the kind of related disability. However, it can have a serious impact on liver function. It can be quite toxic. So it's good to have those baseline bloods as well. So what is the first line treatment for rheumatoid arthritis? Okay, we'll move on. Yeah, DMARD therapies we just talked about. What these DMARDs do is the kind of steps or the chain that, so DMARDs basically modify a step in the chain of inflammation. So if there's a particular point where it modifies some of the proteins, inhibits them, so the inflammatory process can't continue as it normally would. Therefore, it decreases inflammation. So it actually kind of, what's the word? It's actually interfering with the inflammation pathway, the actual mechanism behind it. Whereas an NSAID, something like ibuprofen, that's doing it through like prostaglandin release. So prostaglandin release kind of helps upregulate inflammation. So NSAIDs inhibit that prostaglandin release, whereas DMARDs, they're actually altering the biomechanics behind the inflammation. So which of the following is the most specific investigation? So specific. Okay. So anti-CCP, and it's about 90% specificity. It's very, very specific. The other options, X-rays, they're not specific. Obviously, it's user dependent. It's open to interpretation. And there's also a disease activity score that I'll just mention. But so the disease activity scores are not used for diagnosis. What they are used for is you want to kind of understand, for everyone, pain is different and the arthritis, the impact arthritis can have is different. So you can have a disease activity score, and what that helps inform you of is when we're starting DMARD therapy, do you start them on maybe a quite low to moderate kind of strength DMARD, or is the disease activity score very high, and therefore you would consider a moderate to high strength DMARD to start them on? It's kind of helping inform your management plan at what level DMARD therapy you may start them on. And like a common one will be something called the DAS-28. So it's disease assessment severity score, 28 because it's out of 28 points. Okay, management, these are all your DMARDs. You've got biologics, analgesia. So methotrexate is often a drug that's commonly started. Two things you need to think about when you hear methotrexate: contraindicated in pregnancy because it's a folic acid antagonist, and you can end up with nuchal tube defects with methotrexate. The second thing is liver function. It has some pretty severe impact on the liver, so you need to make sure there's baseline liver checks and regular, maybe biannual liver checks as well. Hydroxychloroquine, that came up in the news a little bit around COVID times. One of the common side effects is hyperpigmentation in the skin. I think there's also some retinal kind of damage that can happen with it. So people often are required to get annual retinal scans as well. Yep, so the DAS28 is one of the disease activity scores. Another one is the Simplified Disease Activity Index. Again, this helps people inform, you've got this list of drugs. Your patient may be appropriate for all of them. The blood tests are fairly well. There's no major abnormalities. So you do your disease activity scores depending how high or low they are. That helps inform you. Are you going to start them on something quite high, moderate potency like methotrexate, or something a little low potency such as hydroxychloroquine? Okay. And lastly, so sometimes carpal tunnel, that can manifest because if rheumatoid arthritis, you do get it in the wrists, so that inflammation of fluid in the wrist, it starts to press down on it's the median nerve that's really affected here in carpal tunnel. So the inflammation swells, starts to press on the median nerve, and it gives someone the whole carpal tunnel syndrome. Now, what you can think about is the cause of the carpal tunnel is actually the inflammation. So you may want to think about giving them some steroid injections or NSAIDs, or the night splits, just hold a hand in the position. Because if they're to flex their wrist, that's increasing compression, and on top of that, you have fluid buildup. So often you give them kind of a hand splint that holds the hand nice and straight, especially when they're sleeping, and that helps release some pain. It's not always that helpful because sometimes when people are driving, if you cock your wrist back, you kind of hold in that position. When they kind of holding steering wheel turning, that's putting a lot of pressure within the kind of wrist area as well, exacerbates carpal tunnel syndrome. But if you hear of a patient with some rheumatoid arthritis complaining of these kind of sensations, numbness and tingling, start to think it could be carpal tunnel. It's one of the consequences of the inflammation. Well, yeah, that's all, folks. So that's a quick whirlwind tour of osteoarthritis, rheumatoid arthritis, some of the considerations you need to make when somebody presents with joint pain, ways of differentiating it, and just a little bit of background into management kind of first steps. There's a QR code for you guys to kind of fill out feedback and things. Is there any burning questions that anyone has?